This meeting is now being recorded.
Hello, everyone. I am Dr. Eileen Thomas from American Sentinel University, and I want to share with you my years of collecting qualitative data and how I use that data to develop first a concept and then an instrument. So just a background to put everything in context. My first study was titled Ring of Silence, A Paradox of Womanhood. And in that study, I had 12 African-American women who had health insurance and at least a college education because I wanted to remove socioeconomics as a barrier to breast cancer screening. And my second study, I repeated the same study using the same methods with Hispanic women. In both studies, the goal was to have women share experiences related to their breast across the lifespan. At that time, there had not been any studies done that looked at how past experiences might impact current health behaviors. My study number 3 was an expansion of the first two, and it was an NIH two-year phase funded study by NIH. And this study had a larger population. It included all socioeconomic levels, and it also included African American, white, Hispanic, and American Indian women. And what I had them do, similar to the other studies, was write journals about any experience they wanted to related to their breasts. So some women wrote stories about buying and wearing their first bra, or going through puberty, or breastfeeding. So the findings from the first study, the themes that came out was silence, and not necessarily silence in the context that you might usually think of silence, but often what is not spoken is more silent. Patients and people in my study shared that they would often go into the doctor's office and they said things like, it's really hard to talk to your doctor when you're sitting on a bed naked, or doctors wouldn't tell them things. They would get results from tests, or they would examine them, but then they wouldn't talk or explain things. They also said, like, when they went in for their first mammogram, which was one of the other topics I wanted them to address in their narratives, that they would just go and stand in the room and the technician would just say, stand here, and wouldn't explain like what to expect, wouldn't explain like it's going to be cold or it may be painful. So that came up almost through every single journal and interview. I forgot to tell you, the women wrote journals. I reviewed the journals, and then I would jot down questions I might have for clarification, or if I wanted the women to expand on something they shared in their journal. So then I would go back to each woman individually, and I had a one-on-one recorded interview with each woman. The other thing that came up is societal contradictions. If you think about it, when you look at a magazine or you see a TV ad or a movie, women tend to be shaped a certain way, and so women get mixed messages about how they should be shaped. Several women told me that they would rather take a chance of dying from cancer, breast cancer, than losing a breast, which might make their mate or their spouse leave them. So women continuously told me that it was important for them to meet societal expectations as far as how a woman's body should be shaped. Every single woman I interviewed, and at this time I'm up to about 78 women I've interviewed at this point, every woman shared one story about teasing. For example, one 65-year-old nurse shared when she was like about 13 and she was going into the school, the custodian opened the door. It was winter time and she had on like a cashmere sweater, and the custodian said, oh, look at those camel humps. Now, keep in mind, she's 65 now. This happened when she was about 12 or 13. So when she was in her 40s, she felt a lump. She waited several months before going in to have it checked out because it brought back this memory, and she was hesitant for anyone to look at her breast. And this happened over and over. I had so many stories about that. Family norms was another theme that played out through all three studies. And I'll say more when I talk about study 3, but particularly studies 1 and 2. For example, in Native American cultures, they have special celebrations to celebrate puberty and the changes that a woman's body goes through. Some families in our culture, they don't necessarily have a formal celebration, but for example, in my family, we would take the teenager out to shopping that day or go out to a special dinner or do something special. So, and then in some families, you know, it's normal for people to walk around the house half-dressed or undressed, where other families, it's very private. You go in a separate room when you're going to change clothes and things like that. So family norms have a lot to do with how you feel about things later in adult. And I kind of touched on media influence, kind of ties with societal contradiction, and I told you that when you look at magazines or you see a movie, you tend to see women shaped a certain way. Womanhood was a theme that came up. A couple of women mentioned it early, and so I had to ask them, what do you mean by womanhood? How do you define womanhood? And some women said womanhood is that unspoken power that women have. But other women said that it's how they're shaped. So that was an important part. And then self-portraits. And I called it self-portraits because what I'm saying here is when women look in the mirror, how do they see themselves in relation to their breasts? Then in study number 3, which was the large study with the 4 different racial ethnic groups and all social economic levels, you can see that some of the same themes came out in that study. So based on all 3 of those studies, I identified a new concept that I call breast conflict. And breast conflict is a latent variable. And a latent variable is a hidden variable as opposed to a variable that can be observed. It's inferred from other variables that we can observe. So the way I define breast conflict is it's the oblivious discord women experience regarding personal feelings about their breasts. There's this ongoing conflict women have internally that they may not even be aware of that is going on, but it's all about how women define themselves in relation to their breasts. So some parts of society, it says it's good to show your breasts, and in other sides of society, it says you don't show your breasts. So it's this ongoing internal conflict that I have found that does later in life impact a woman's decision to participate in breast cancer screening, particularly mammography screening. And so I am saying that the major contributors to breast conflict, if you think back to the themes that came up in all 3 of my studies, teasing is a major contributor. I say that because every single woman I interviewed, without me initiating it or asking, brought up and shared a situation where they felt that they were teased. There was one lady that, some of the stories are very, very funny, you know, and the things that young girls do. I mean, one girl put clothespins on her nipples to make her breast larger. Another lady was when she was a child or a teenager, she was spending the night with a cousin, and a cousin said, well, you know how baking soda makes yeast rise? So get a washcloth, wet it, put baking soda on it, make a paste, lay it on your breast, and you can't move all night. It has to stay there all night, and in the morning, your breast will be larger and rise just like bread does. So needless to say, you know, that did not work. Society and media, strong influence and contributors to breast conflict because, like I explained on previous slides, society kind of tells women this is what women are expected to look like. The media tells us that in movies and things like that. And then finally, family norms and values. How I explained how some families are very open about dressing, undressing, sharing things about your body where other families don't do those types of things. And then the main thing about breast conflict, it really does start, I found, during adolescence, but it continues across the lifespan, and it impacts attitudes, beliefs, and behaviors related to mammography screening. So I just want to very quickly share difference between statistical models and measurement models. So statistical models, which most people are familiar with, they're oriented to variables that address populations. They're at the population and sample level, whereas measurement models are focused on the individual level, the individual response. So I'm going to share with you my women's breast conflict scale is what I called my instrument, measurement model. And so I am saying that right here, breast conflict directly impacts women's attitudes, beliefs towards mammography screening, and that what contributes to breast conflict is body self-image. And for that item, I have 14 questions on my scale. Societal medial influence, there are 6 items, and I'll tell you more about items on the next slide. Teasing, there are 5 items or questions on my scale or instrument. And then family norms and values, there were 8 items. I recognize that there's other barriers that contribute to whether a woman will participate in mammography screening or whether a woman will follow the recommended guidelines. The other unique thing I believe about my instrument is not only will it be able to predict if a woman is likely not to participate in breast cancer screening, but it's going to be useful in identifying those women who, once they are diagnosed with breast cancer, if they are least likely to follow recommended treatment guidelines. So now I'm going to get into, this is how you develop an instrument. First, of course, you have to determine what is to be measured, and there's 8 steps. I won't go through reading all the 8 steps on this slide because on the following slides I'm going to explain each step. So first you determine what you want to measure. Typically when someone is developing a scale, an instrument, a questionnaire, survey, whatever you want to call it, it could be based on a theory. For example, the health belief model. There are many instruments or questionnaires that have been developed on the health belief model. Another way you can do it is get focus group input. So I could have chose to gather groups of women over periods of time, get their input, and based on their feedback and comments, develop questions for a scale or instrument. What I did, though, was the third bullet. I used qualitative themes and categories to identify the items on my instrument. And then the fourth way that people might develop an instrument is based on a review of the literature. So as you can see, and as I've been sharing, my women's breast conflict scale, which I call the WBCS, it's based on what I found related to body self-image, family norms and values, teasing, and society media influence. The second step in developing an instrument is to generate an item pool. And that means you're going to select what items reflect the purpose of your scale or your instrument. The purpose of my instrument is to identify breast conflict because I am proposing that the higher degree of breast conflict a woman has, keeping in mind that this is usually it's not recognized, it's something that happens internally, but my purpose is to identify the level or the degree of breast conflict because I am saying the higher degree of breast conflict the least likely a woman is to follow recommended guidelines for mammography or to follow treatment guidelines once they're diagnosed with breast cancer. And then you need to know the number of items. The larger number of items initially to start is better, and I'll explain why later. And then you want to make your questions very clear. You don't want long questions. You do not want compound questions, so you're really asking two things at once. And you want to try to aim for a reading level between the 5th and 7th grade. So here's an example of how I took different quotes throughout all of my studies, and you can see how I connected them to a theme, and then I developed a scale item. So the first one, for example, I referred to puberty as a heartache because I did not know what to expect, and that came under the theme of self-image, self-portraits. And so on my instrument, the question is, I looked forward to the physical changes that would occur. I have statements rather than questions, and I'll tell you more about that a little bit later. And so I have 4 subscales related to the 4 themes that you see here on this slide, and you can see how the different quotes kind of tie into the theme and then how I developed the scale item. So I'll go to the third one down is, wow, never knew she had such knockers, or because of all that early teasing to this day, I think of my breast as a nuisance. So, of course, that came under teasing. And then the scale item on my instrument, one of them is, boys said things about my breast that made me feel bad. And you can see on the far right, first at the top, all of these questions, and women are instructed to think back to when they were between the ages of 12 to 18, because remember I said that I am proposing that breast conflict starts during adolescence. And so you can see there's internal influence, there's external influence, and those are the things that all contribute to breast conflict. The third step in developing an instrument is to determine the format. And so on this slide, I have examples of 4 different ways that you could format your questionnaire, your instrument. I chose the very first one, and some of the lines kind of got moved in uploading and everything. But number 1, for example, would be, and keep in mind, you see it says, when I was 12 to 18, I felt embarrassed to have breasts. And then the women are instructed to circle the number that most likely applies to them. So 1 would be extremely true for me, and 5 would be extremely untrue for me. I could have chosen to put agree, disagree, or yes or no. Another option, you can use a visual analog. So the bottom one is not at all, and then most embarrassing experience ever, and then the women would be instructed to put a little check mark or an X where they feel they fit on that line. The 4th step is to have your initial items reviewed by experts, and earlier I said the more questions, the better the initially. And so I had 7 professional experts, and what I did is I divided the United States up into quarters, and then I went online and identified large universities in each quarter, and then I went to the university site to try to find nurses that had done research in this area, research related to breast cancer or breast cancer screening, or they had developed instruments. And then I felt, because I wanted women for whom this instrument was developed to participate in the development of it, I identified 7 laypersons. What I did is I posted an announcement in a large campus university area and a large urban area, and asked women would they help me with developing my questionnaire, and 7 women responded. And because I had African American, white, Hispanic, and American Indians in all of my prior qualitative study, I wanted a similar mix to review the questionnaire. I was not able to find any American Indian women, but I did have African American, Hispanic, and white. And what you have the experts do, both lay and professional, is rate the relevance of each item, the statements that I showed you on the prior slides, to the latent variable breast conflict. And then their responsibility was to either accept or reject the question and then share advice on what could make the question clearer or what could make the question more relevant to each domain of the questionnaire. And the way you do this is with what's called a content validity index. Some of you may be familiar with a face validity, where you kind of look at the questions and you go, okay, yes, that question fits with teasing. Yes, that question fits with body image. But this one is different, and you're looking at the extent agreement between all the experts. And what you do is you take the number of experts that say that the question strongly or most likely fits the construct that's being measured, teasing, for example, and you divide it by the number of questions in that domain. And what you want to get is a level about 0.80 or higher. So this is the document that my lay and professional experts saw. And I asked them to circle the number. Did they feel that, for example, the item number 1, puberty was not a time of celebration for me? Did they feel that that was relevant to the external influence, family norms, and values? And I had a form of these for each of the domains of my study. The teasing, the family norms and values, the societal, media, all of those, there was a form for that, and they circled if they felt that it was relevant, if it needed minor revisions. And so back to content validity, you look at the number of experts that circled 3 and 4, you combine those to get your 0.80 or higher, hopefully. The 5th step is to consider including validation items. Often people, when you're doing a research study or you're sending out questionnaires, especially if you're present when they're completing them, or, you know, you're going to give an incentive for completing, sometimes individuals will answer the questions that they think is socially acceptable. So you can use another form of validation to determine how likely this person was being honest and truthful in their answer, or if they were just answering to please the researcher. So after I gave the form to all of both the lay and the professional experts, they did have some recommendations, but you can see items 2 and 3 on this slide. They had a mean agreement between the experts of 0.86 and 0.93, and like I said, you want to be at 0.80 or higher. If it's lower than that, you need to either toss out the question or you revise the question. Now, item number 1, I look forward to the physical changes that would occur during puberty. And you could see, in the first column, COMM, that's my lay, the community professionals, and then professional experts, and then I took the mean. I did not revise this item because when I went to explain, and I went individually to each of the layperson and explained to them verbally, this is what I want you to do. I don't want you to answer the question as if you're answering that you look forward to the physical changes. I just want you to read the question and tell me, do you feel that it fits with the topic that it's under in my questionnaire? Unfortunately, some people answered the questions as if they were personally answering the questions. Like, I compared my breast size to my peers, and one person wrote, yeah, I compared my breast size to my peers. My uncle told me that I should do that, you know, that I was smaller than all my girlfriends, or something like that. And so I did make a small change and changed it to I compared my breast size to my peers' breast size. And similar to number 3, the revision was having my breast touched by a healthcare provider made me feel uncomfortable. Now, I said a few minutes ago that you want your content validity index score to be 0.80 or higher. And you can see on 2 and 3 they were higher, but the experts made recommendations on ways I could rewrite the items so that they would be clearer, and I did that. So the next steps after you do all of that is to administer the instrument to a sample group, evaluate the items using traditional psychometrics, and then you optimize the scale length. The step that I'm at now is I've done the initial psychometric test, and it's not unusual once you run it through, you find out that there's items that you need to toss out. So I had to get rid of about 9 items, and the next step for me, hopefully that I'll one day get to do, is to rerun the test again and then administer the instrument to a small group, and then you have to do the psychometric evaluation. And when I say psychometrics, I'm talking about the validity and the reliability of the instrument. So that's where I am in the process. Long term, I would like to do a predictability validity to determine if this instrument will be useful in predicting behaviors, predicting either mammography screening behaviors or cancer treatment behaviors once diagnosed with breast cancer. So just to recap, peers were identified as women in the community who could benefit from the instrument, and these were the women who could very well be women that might eventually be able to use this instrument, but they were what I called the lay experts. And then I had professional experts to review the scale items and rate them on a scale from 1 to 4 for clarity and for relevance, and to suggest revisions if the statements were unclear. Using professional and community experts, it served as a check. If you're familiar with qualitative research at all, it was kind of a form like a member check on the findings from my qualitative data that I used to provide the basis for this new instrument. Some of the challenges, several members, like I said earlier, they answered the questions personally. Even though I went physically to each individual layperson and explained, this is what I need you to do, and, don't answer the questions personally, and I gave them examples. What I would do the next time is I would do a mock validity and clarity assessment for the lay experts with myself or another researcher, in addition to the oral and written instructions, and then hopefully they would not answer the questions personally. So I hope that you have a better understanding of how I developed an instrument, or how you might develop an instrument using qualitative studies. Thank you for listening to my presentation.